my name is Liz Enderly. I'm going to be your DNP student today. Is it okay if I call you Jocelyn?
Yeah.
All right, nice to meet you, Jocelyn. Do you have any questions about what a nurse practitioner does?
No.
Do you kind of have an idea of what nurse practitioners do?
Mm-hmm.
Perfect. So what I'll be doing today is performing an assessment, and so we'll just go from there.
Okay.
Wash my hands first. And I would make a note of her general appearance. So she appears calm, she's not in any acute distress. So what we're gonna do first is the abdominal exam. So what I'll have you do is go ahead and lay back. Alright. So what we're gonna be looking at are the 9 quadrants of the abdomen. We're gonna first start with inspection, so I'll look for symmetry from different angles, just making sure there's no difference on either side. Also looking for the contour. Is it flat? Is it rounded? Is it concave? Looking at skin for any scars that could give us any ideas about past abdominal surgeries, C-sections, that sort of thing. Looking at the umbilicus for any bulges, any inflammation that may be present. I'm not seeing any. Your abdomen is symmetric, it's flat. We want to check for any visible peristalsis, which we would see, and then also any aortic pulsations. So what we're going to do next is I'll go ahead and auscultate. So I'm going to listen in each of the 4 quadrants. And I want to make sure I'm noting the frequency of the bowel sounds, if they seem to be hypoactive, hyperactive, and if there's any abnormal sounds like really loud gurgling, or there can be kind of just all types of different sounds that could indicate like a bowel obstruction or something like that. Next, I'll go ahead and listen for bruits. So we're going to listen over the aorta, the renal arteries, the iliac arteries, and the femoral arteries. Let me go ahead and put this pillow under your knees. Should have done this at the beginning to make it a little more comfortable. All right. So moving forward, we can also listen for any venous hums. So we're going to want to listen over the liver and the spleen for that. So next we'll move to percussion. So what I'll do is I'll percuss just generally around the stomach, and then more specifically, what I'm going to do is divide up the 9 quadrants and kind of go from there. And just noting any dullness, tympany, if there seem to be any abnormal qualities of the percussion. So next we can measure the span of the liver. So I'll do that along this midclavicular line. I'll go ahead and percuss upward first, noting any changes in sound. All right, and then I'll percuss downward. And I can note the difference between the 2 areas that I percussed. That would be the span of the liver. Next, I'll go ahead and assess for any splenomegaly with percussion. So I'll do this along the side. not noticing any changes in the percussion there. So next what I'll do is I'll go ahead and palpate. First we'll do light palpation in each of the quadrants. Just feeling for any masses, any tenderness to light palpation. All right, and then we'll go a little bit deeper, noticing if there's any guarding, any tenderness with the palpation.
Mm-mm.
Sorry,
Maybe there.
a little tenderness over there.
Yeah.
All right, so what we'll do next is we can test for any rebound tenderness. This would indicate inflammation of the peritoneum. So usually we do the rebound tenderness in the
I'm scared.
lower left quadrant. I'll just go ahead and push down and then go ahead and relax and pull back. Was there any pain?
No.
Usually if there's
Scared.
any sort of inflammation, we would feel pain kind of located usually in the right lower quadrant. Following rebound tenderness, we can palpate for the liver. So I'm going to go ahead and support the side of her, the right side over here where the liver would be, and go ahead and palpate here. So go ahead and take a deep breath. Take a deep breath again. All right. And I'm not feeling the edge of the liver, but if the liver was enlarged, we would be able to feel the edge of it. If I did feel any masses on palpation, I would want to note their location, the consistency, the shape, size, if there was tenderness associated with it. And then next what we'll do is we'll palpate for the spleen. So I'm going to reach across and support over here. Go ahead and take a deep breath. You can let it out. And I'm also not feeling the spleen either, which is good. We can also try to palpate the kidneys. So for this, I'll support behind and kind of palpate more directly backwards. Same thing. And I'm not feeling the kidneys on palpation. Finally, what we can do is palpate for the aortic width. So I'll feel for the aortic pulse. And then feel the width of the aorta. Just checking to see if there's any sort of possible aneurysm present. Finally, there are some special tests that we can do. I'll have you lay down for the first couple and then I'll have you sit up to check for the CVA tenderness. But first what we'll do is we could test for ascites. For testing for ascites, we would palpate outward kind of in a stellate pattern to note changes between tympani and dull. And then what I would do is have her lay on her side, palpate in the same areas, and we would notice shifting of the areas that were either tympanic or dull, where the fluid is collecting once she rolls to the side. To test for appendicitis, we can do the Rovsing sign. So if I'm palpating in the right lower quadrant, she would be feeling pain in the left. Are you feeling any pain?
A little. That's fine.
We'll have to get you checked out after this. We could also check for the the Rovsing sign, or the psoas sign. So we're gonna lift the leg up like this, and then go ahead and try to flex your hip. Is there any pain with that? Good. And then we can also turn the knee in for the obturator sign. Is there any pain with that? Good. All right. And then finally for cholecystitis, we can palpate up near the liver again. I'm gonna palpate up in this right upper quadrant, have her take a deep breath. And if there's any pain on inspiration, then we can look further into there being a possibility of cholecystitis. So So go ahead and take a deep breath. And there's no pain that seems to stop inspiration. So, all right, I'll have you go ahead and sit up. Check for CBA tenderness. So for this, I'm going to place my hand. It's kind of hard to see. I might move it real quick.
Want me to do this?
Yeah, that would be great. So I'll place my hand kind of at that costovertebral angle. Is there any pain with that?
No.
Good. All right. And that is the abdominal exam. All right. Next, Jocelyn, I'm going to be doing a peripheral vascular exam. So first I'm going to start with inspection. So I'm just going to look basically, we'll start with the top. I'm going to look basically from your shoulder to your fingertips. If you want to extend your arms, that way I can get an easier view too. I'm just looking for color, I'm looking for symmetry, I'm looking for any swelling. Different conditions like maybe a DVT would cause a change in color or swelling, lymphedema as well. Just from different angles. And your arms are symmetric, I don't note any swelling, I'm not seeing any changes in color. I'm going to look at your nail beds. I could assess for clubbing if we put your fingers together. All right, your nail beds look normal. I'm not noticing any clubbing. And also looking for venous patterns if there's any like enlarged veins that might be present, prominent veins, that sort of thing. Next, what I'll do is I'll inspect the lower half, so groin to toes. Again, looking for the same things, color changes, swelling, and symmetry. So go ahead, yep, stand up. I'll look from a couple of different angles. Oh, perfect. All right. We want to look anterior, lateral, posterior, and everything looks symmetric. Obviously, she would be in a gown for this, so I would be able to see skin color, all that good stuff. Again, looking at nail beds, but of the toes. For this, I would have her take off her shoes so I could inspect the toes. And then also looking, especially for distribution of the hair on the lower legs, feet, and toes. If there's abnormal hair loss that we note, it could mean peripheral arterial disease. So we would want to investigate that further. We would also be checking for any varicosities on the lower legs. We would have her, as she did, stand up so that we could have adequate blood drainage. If she's sitting down, we might not see that as well. And then just noting any pigmentation, any hyperpigmentation, any scars, any sort of ulcers, especially on the feet, under the feet, on the soles, the toes, for those diabetic patients, just making sure that they don't have any sort of injuries that they're not aware of. Next, what I'll do is I'll palpate. So for this exam, I'm going to palpate your radial and brachial pulses. Both sides, kind of comparing each side. Your pulses are strong. I would give them a +2. They're equal on both sides. I would note that they're regular. There didn't seem to be any skipped beats or just abnormal sort of beats for that. I'll go ahead and I'll try to feel for any epitrochlear nodes. So go ahead and we'll put it at a 90-degree angle. And these we feel kind of in between the bicep and tricep if they're present. I'm not feeling any. I believe these are present in lymphedema, that we're able to palpate these. All right, good. So next, I'm gonna put on some gloves and I'll have you lay back. I'm gonna feel for femoral pulses, popliteal pulses, and the inguinal lymph nodes. And again, for a normal assessment, Jocelyn would be wearing a gown so I could get a better picture. So feeling for femoral pulses. While we're here, I'll just palpate for inguinal nodes. Okay, and then popliteal pulses on each side. Lift up here. Okay. Just noting again if they're equal, if they feel strong or weak or thready, if there's an abnormal rate. Good. All right. For a normal exam, again, we would have shoes off so I could feel the dorsalis, dorsalis pedis pulse, and the posterior tibial. Again, assess on this side. Good. All right, go ahead, you can sit back on. What I'll do next is I'll assess the temperature of the legs. Use the backs of my hands. Noting if there's any changes from different cool spots or warm spots. And assess the temperature of the feet and toes as well. I would palpate for any edema. And if there was any edema, I could check for pitting edema along the shins, along the sides of the ankle, and along the dorsum of the foot. Just holding pressure for like 5 seconds and seeing how long, or if there's pitting edema. It's kind of obvious. And then I'll assess for cap refill. So I'll go ahead and assess these fingers. Cap refill is good. I would also assess the cap refill on the toes, doing the same thing again as with the fingernails. And finally, any special tests, we could do the Allen test, which is occluding the radial and brachial arteries, or ulnar, radial and ulnar arteries, and have the patient kind of pump their fist, get all of the blood out of their hand, and let go on the ulnar side to make sure that circulation comes back if we were going to do a radial puncture for blood gases. We could also check for arterial insufficiency of the legs by raising the legs 30 to 60 degrees for about a minute, making sure the blood drains out, and then have her dangle her feet back like this, and circulation should return within about 10 seconds. So that's the peripheral vascular exam. All right, so Jocelyn, next we're gonna go ahead and do a cardiac exam. So for this exam, we've got the head of your bed elevated. We want that at 30 degrees. I'll go ahead and I'll have you lay back, because first I'm just going to inspect. I'm gonna look for, here, sorry about that. Inspect for your jugular venous pressure, looking for your pulse up here. All right, and we can shine the light. Yeah, go ahead and turn your head away from me a little bit. All right, perfect. And also just assessing the carotid pulse as well. That's what, yeah, the carotid pulse. Just looking for the pulsations of the pulse. We could also use tangential lighting to illuminate where the PMI pulsation is. We want to look along the midclavicular line, right around the 5th intercostal space, kind of right under where a bra line would be at. We would also use the tangential lighting for that. So what I'm going to go ahead and do next is measure your jugular venous pressure. So go ahead, place this right at place this away from you, right at the sternal angle. I'm going to look to where I see the pulsations and measure over. So just about 2 centimeters. So what I'll go ahead and do next is I'm going to palpate for the carotid pulse. So just breathe in normal. We want to feel for this kind of right above where the clavicle is. Good. Wanting to make sure that we're feeling equal pulsations on both sides. We don't want to include both at once. We want to feel for the amplitude, kind of noting if it's a really bounding pulse, if it feels thready. We can tell if it's really brisk or very slow. We'll go ahead, also at the same time, we want to be noting if there's any thrills, so we would be feeling a vibration there if there was maybe some carotid stenosis. Next I'm going to go ahead and palpate the PMI. So I'll come over here again, kind of right under. And I'm going to use my whole hand first just to get kind of an idea. All right. So again, we feel the PMI kind of right on the 5th intercostal space along that midclavicular line there. I'll go ahead and I'm going to palpate the left sternal border next. We're kind of feeling for the right ventricle, or not the right ventricle, the left ventricle. So right along the side of the sternum, between the 2nd intercostal space and the 5th intercostal space. And then we'll feel along the right side of the sternum, along the 2nd intercostal space. Good. Just to note that pulmonary artery and aortic on the right side, pulmonary on the left. So next I could do percussion. If I wasn't able to palpate where the PMI was, I could percuss along the side, laterally and medially, to percuss where the cardiac dullness is located. And then finally, I'm going to go ahead and listen. First, I think it's a special test, but I'll go ahead and I'll listen for carotid bruit on each side. So go ahead and hold your breath for a second. All right, you can let it out. And then hold your breath again. Perfect. All right, so I'm not hearing any bruit. You can go ahead and breathe if I didn't tell you or you didn't. Just wanting to make sure that the patient understands that they are able to breathe again. So next I'll go ahead and I'll listen across the chest, listening for in the aortic area, pulmonic, Erb's point, the tricuspid, and then the mitral valve, kind of located at the apex. I'm going to go ahead and switch to the bell side. I'm going to listen again at the apex and then up along the left sternal border. All right. Next, I'm going to go ahead and have you kind of turn to your left side. I'm going to listen in the left lateral decubitus position, just noting if there's any S3 or S4 sounds. And this will be listening for the apex. All right, I'm not hearing any extra sounds. I'm going to have you, we'll go ahead and you can sit up. And then I'll go ahead and have you lean forward. I'm going to listen again along that left sternal border and the apex. This is listening for any sort of aortic murmurs. I'm not hearing any aortic murmurs. I'm not hearing any splitting of S1 or S2. I would, if there were a murmur, I would want to note its timing, the intensity, the location where it was heard. And then just generally noting the rate and rhythm of the heartbeat, making sure that there's no extra sounds that we're hearing. And then if there were a murmur, I would want to describe the intensity, the location, the shape, all those different details, the timing, where it happens within the cardiac cycle. So that is the cardiac exam. All right, and finally, Jocelyn, we're gonna go ahead and do a respiratory exam. So first what I'm gonna do is, generally what I would do is inspect. I'm gonna make sure that Jocelyn's not having any respiratory distress. So is she sitting in the tripod position? Is there intercostal pulling? Is there supraclavicular pulling? Looking for tracheal deviation, looking at the respiratory depth and effort. Is she really trying to get a good breath with expanding her lungs? And I would want to look from a couple different angles again, just noting respiratory effort. Effort looks easy. I'm not noticing that she's in any sort of distress. Also want to be looking generally at color. We can assess for cyanosis again with the patient's lips, mucous membranes, fingertips, all of that. Just looking for any sort of respiratory distress again. We could also listen for any audible wheezing, so using a quiet pause. I'm not hearing any audible wheezing. Again, breathing seems pretty easy and clear. Like I said, noting any accessory muscle use of the intercostals, any retractions that are present, and would notice this both anteriorly and posteriorly, just in assessing. So next, what we're gonna do is inspect for symmetry and just general, making sure that the contours of her thorax are what we would expect. Any deformities, both from anterior, posterior, we could look laterally as well. Want to note the AP diameter, so the diameter of the anterior chest to the lateral and posterior. So seems like the AP diameter is like a 2-to-1 ratio, basically, what we would expect again. And then just noting again any asymmetric or impaired respiratory effort. Is she having a lot of trouble breathing? Are there any abnormal movements with the lungs that we wouldn't expect? And just looking again at all angles. So next what we're gonna do is palpate. So if there were any areas of pain, we can always palpate. Are you having any pain? If there were any lesions or bruises, we could also palpate in those areas. To assess for chest expansion, I'm gonna put my hands, maybe I could have you just turn like a tiny bit that way, yeah. Put my hands along here, nice and tight. All right, go ahead and take a deep breath and let it out. And just noting that each side of the chest expands symmetrically with that movement. Good. Following chest expansion, we can also assess for tactile fremitus. So go ahead and say the word 99, and I'm gonna feel for any differences in vibration.
99, 99, 99, 99, 99, 99.
Good. So we could note if there were any differences in vibration within all of the lung fields, and that could indicate consolidation. We could also do the same thing on the front, kind of going in that ladder pattern and along the sides as well. So next what I would do is percuss. So I'll go ahead and percuss anteriorly first. I'm just trying to aim for those intercostal spaces, noting any differences between tympanic or jaw areas. In the front, we want to do the ladder pattern. In the back, we just kind of go along down the sides on each side. And then I could also percuss for diaphragmatic excursion. So we could do this along the back. I would have her kind of hold her breath, palpate for the general edge of where the diaphragm would be, and then have her take a deep breath in and hold it, and then palpate up to see the difference between where I hear the difference in sound when there's no lung expansion versus the full expansion with the deep breath. Excuse me. All right, and then next I'll go ahead and I will auscultate for breath sounds. So go ahead and take a deep breath in and out of your mouth, okay? Same thing in the back. And in listening for breath sounds, I just want to make sure breath sounds are clear. I want to note the pitch of the inspiration, noting if there's stridor or any sort of wheezing, if there's changes in the intensity of the sound, and then if there's any wheezing either on inspiratory or expiratory effort. If there's any crackles, rhonchi, other abnormal sounds that we wouldn't normally hear. A special test that we could do is post-tussive auscultation. So if the patient has a really bad cough, we can listen right after they cough to know if the lungs sound more clear, kind of noting if they're able to clear their secretions. And finally, we could do the voice transmission test. So similar to the tactile phragmatus, with the patient saying 99, we can listen, auscultate for changes in frequency of sound. So bronchophony, I would have her say 99. I would listen all around, noting if any of the areas that I listen in are more clear than others, and that can indicate consolidation. The whispered pectoriloquy, I would have her whisper 99. And again, notice if I'm hearing the whisper louder in any different areas. And then for egophony, I would have her say E, E, E. And if there was consolidation, the sound would change to ah, ah, ah. So we could do all of those too if needed. And that is the respiratory exam.